Dear Chairmen, ladies and colleagues, thank you for inviting me. Not anymore from Germany, now from Austria, from Innsbruck, but I'm happy to be here. And I would like to speak about the systemic factors which influence the DME treatment results. These are my disclosures. And I think everybody of us know these two examples, two very similar patients starting with similar findings and visual acuity and impairment due to macular edema. We performed the treatment, and after 1 year, the first patient is completely dry, the second one presented persisting edema and the reduced vision. The question is, do we predict this prognosis? Are we able to predict it? We heard something about all these different morphological parameters which can be used as biomarkers for prediction of the visual prognosis. However, even using of different very complicated big data models with support of artificial intelligence, we are not able to be better than with a prediction value of about 70%. So there's probably something more behind the diabetic eye. There's a diabetic body and a lot of systemic parameters, and I would like to focus on this one. We have a very good data from large population studies regarding the development of retinopathy and diabetic macular edema. We know that there are race differences, that the Africans, Americans have a much more higher risk to develop the diabetic retinopathy or macular edema once they are diabetics. Even the men have a higher risk to develop diabetic retinopathy than the women. We know that for each single year of diabetic duration, the risk for development of diabetic retinopathy increased with 1%. There is a clear correlation with the blood sugar control and the increase of the diabetic retinopathy prevalence in the patients which are not well controlled. Even the waist-hip ratio, as obesity and overweight, is also increasing the prevalence of the diabetic retinopathy, and of course the blood pressure control and the renal function. However, this is not saying anything about the treatment results once we decided to treat the patients because they have a diabetic macular edema. So looking to the big data from the pivotal trials for aflibercept with the VIVID and VISTA post-hoc analysis, the studies subsequent, or they divided the population into 4 subgroups according to quartiles of blood sugar control or blood pressure control. However, the correlation between these baseline systemic parameters and final functional outcomes was not presented. So there is no relevance of these systemic parameters at the baseline. Very similar data was found for the ranibizumab from RISE and RIDE trial. Even here, there was no correlation between these systemic baseline parameters and final visual outcomes. So this is a little bit disappointing, but we know these selected trials, these pivotal trials are focused on a very selected population, which is not in line with our daily, routinely populations we are treating in. So we performed a LIPSIA trial. This was in Germany, in Leipzig. I was working before, and we included all patients coming to our department. It's a university department with treatment requiring diabetic macular edema, and we performed a huge panel of systemic parameters which were evaluated 24 hours, blood pressure measurement, the blood controls, so it means the blood samples were investigated for several parameters. You can see divided by inflammatory, metabolic and renal parameters and cardiovascular. And we treat all these patients with aflibercept for 6 months, and we checked again these systemic parameters after 6 months. So what we find is a little bit surprising, and it's stunning that the mean systolic blood pressure was in these 90 patients, more than 140 eyes. The mean systolic blood pressure was 195, and you can see that the majority of the patients is out of the a range which is recommended, so more than 140 millimeter mercury. You can see that the blood pressure over 160 was found in more than 50% of the population, and more than or almost 50% of our patients had the maximum value of the blood pressure during the measurement more than 200. Looking to the blood parameters, the blood sugar control was, as we know it also from other studies, between 7.2 to 7.3. There was a significant reduction of the creatinine and glomerular filtration rate. So this is a overview of the characteristic of our study cohort. You can see that more than 80% of our population do have a dyslipidemia, overweight, more than stage 2 chronic kidney disease and hypertension, which is not well controlled. And now the correlation between the systemic parameters and visual outcomes after 6 months, something what is not surprising, we heard it also from the DRC networks, worse baseline visual acuity in lower age are associated with more pronounced visual gain. So it means the better the baseline vision, the less likely will the patient gain more than 5 letters. It's clear you are starting lower, the possibility to improve more, it's higher. But what we find, and it was the only one correlation we found from the systemic parameters, is that the normal glomerular filtration rate is leading to better functional outcomes, and there's a huge difference. Once you have a patient with a normal glomerular filtration rate, the probability that or the improvement of the vision after 6 months will be more than 10 letters. The same patients with lower renal parameters will improve only 2.9 letters. We know that baseline visual function and age is influencing our results. So therefore, we adjusted the glomerular filtration data to the baseline and age parameters, but there's still significant influence of the renal parameters. It means that the patients with a normal glomerular filtration rate will improve 7.7 letters compared to 3.9 letters in a population with reduced renal parameters. We couldn't find any correlation with blood sugar control, so HbA1c levels or lipid levels in our study population. So we now can look at the other studies from other authors. There's a Chinese population published last year. They find also a significant correlation between the subretinal fluid, the presence of subretinal fluid, and the patient with albuminuria, which is the last stage of the kidney, chronic kidney disease. And very recent data coming from this year, but a small cohort of 30 eyes also observed a strong correlation between the functional results after 1 year treatment with aflibercept in the patients according to the duration of the diabetic disease, so the diabetes duration, and also for the glomerular filtration rate. You can see that a patient with reduced glomerular filtration rate would had a smaller reduction of the macular edema and also smaller visual gain. However, the fine retinal blindness registry, which was published also this year with more than 170 eyes, could not find any correlation between the sugar control and glomerular filtration rate. So this is a little bit disappointing. This was a large population. Even you can see the tendency that the patients with a reduced glomerular filtration rate are starting lower, and also the improvement, even it's in line, they will end it with a lower functional gain. So there is some tendency, but they was not able to get the significance letter. Probably maybe one of the explanations may be the lack of the data. This is a retrospective analysis. There's no presence of all the data regarding the renal parameters from all these patients. However, I can conclude that the morphological ocular parameters, which are predominantly OCT-based, do not fully explain the visual prognosis in our DME patients, which we are treating. The systemic parameters and their role regarding the prognosis of the diabetic macular edema treatment is still not successfully explained. We have a very good data showing that there's a clear correlation between the systemic parameters and development of the macular edema or diabetic retinopathy, but we still need a further larger prospective trials which would explain us the role of the single systemic parameters, as we have some signals that the renal parameters might influence the final prognosis in our patients. Thank you for your attention.
And thank you for a very interesting talk, which is open for discussion. We're a bit late, but I'm sure there's some time for 1 or 2 questions. So how would you translate this in your clinical practice?
I think that's a good information, because we used to ask what is your blood sugar control, what is your HbA1c level, but nobody asked before how is your renal parameter status. So this is something what we added now.
Okay, very good. everybody's leaving, so I think we're joining. Thank you very much for your talk. And thanks all the speakers and your audience. Bye-bye.